Good day to everyone. I'd like to thank our partners here at Heart Center for the opportunity to update myself and to share about acute kidney injury and cardiorenal syndrome, which is indeed a complex interplay in the clinical setting. So, at the end of the 30 minutes, I hope that we'll be able to discuss the epidemiology of AKI in relation to cardiovascular disease, discuss the different cardiorenal syndromes, and its diagnosis and management in our center. So the prevalence of acute kidney injury in critically ill patients is high. About 5% ICU patients require dialysis, and hospital-based mortality based on this data and other data range from 40 to 60%. There is an interplay with AKI and cardiovascular events. In these different kidney reviews, we can see that those with acute kidney injury have a high chance of having heart failure and all-cause mortality. We can also have cardiovascular events even after discharge from AKI. And also, we can have AKI in COVID, and death is much increased. But also, for the compensated heart failure, we can see that acute kidney injury can really increase, indicating that there's an interplay between the kidney and the heart. In the Philippines, renal disease is the fourth leading cause of death and is the highest PhilHealth reimbursable in terms of hemodialysis. So its burden is really increased. For today's lecture, we hope to diagnose acute kidney injury because it's quite common in our center. And if we recall, the KDIGO definition in 2012 is still largely the one we use. There are three stages of AKI with increasing numbers, showing worsening serum creatinine and decreasing urine output. So the important thing to note is that when you reach AKI 3, usually renal replacement therapy is an option, which can be three times the baseline of the increased creatinine or an increase in creatinine of greater than 4 milligram per deciliter. But always remember that the creatinine increases 48 to 72 hours after the insult, so the urine output will be the more sensitive marker and the earlier marker of acute kidney injury, occurring when the patient has a urine output of less than 0.3 ml per kilo per hour for 24 hours or anuria for greater than 12 hours. So given this, we can identify AKI in this clinical case. If we have a female with a serum creatinine baseline of 1.8 who came in for bypass, weighing 60 kilograms, but was referred post-op to the nephrology service for a urine output of 6 ml per hour, which is computed at 0.25 ml per kilo per hour. And when CREA was repeated, it was 4 milligram per deciliter. We can ask ourselves, what is the stage of our kidney disease? So acute kidney injury is a kidney injury occurring in less than 3 months. And here we can have these two columns wherein the patient has an initial CREA of 1.8, which increases to 4. But we can also consider that the patient will be in stage 3 because the creatinine is already greater than or equal to 4. But more sensitive is that we know that the urine output of the patient is 0.25 ml per kilo. So when we compare the different criteria for AKI, we need to remember that the more severe one, in this case, we're considering if it's 2 or 3, based on the different category, we'll consider the more severe one and stage the patient accordingly. So our patient is in AKI stage 3. However, I cannot go into this without also touching on cardiovascular surgery associated AKI because our center accepts a lot of procedures. So for cardiac surgery associated AKI, it is defined as a serum creatinine level usually above 2 if the baseline is less than 1.5 milligram per deciliter, or if the baseline is at 1.5 to 3, a creatinine increase of over 50%, the baseline value can already alert us to AKI possibility. This is important in order for us to see their other risk factors for AKI and try to prevent it in order to try to decrease the progression to acute kidney injury if we can. Now, let's go into the meat of the discussion, the cardiorenal syndrome, which has been rapidly evolving over the last 15 years. and is defined as acute and or chronic dysfunction of the heart or kidneys that can induce an acute or chronic dysfunction of the other organ. So by definition, it's important for us to note that this is bidirectional, may be acute or chronic, and its classification depends on these two. What it means essentially is that the heart can affect the kidney and the kidney can also affect the heart. So it's the worsening of each condition entails the need to treat both at the same time. Here we have the stages of the cardiorenal syndrome. There are five types, and then for type 1 and 2, the way I memorize it is that the heart is the leader causing injury to the kidney. And then usually the odd numbers are the acute cardiorenal syndrome. So type 2 is chronic, and then if we go to type 3 and type 4, it's the cardiac syndrome, wherein the kidney is injured first, then affecting the heart. So type 3 is acute and type 4 is chronic. Type 5 cardiorenal syndrome would arise due to a problem in other body systems affecting both the heart and the kidney at the same time. So for acute CRS, we have heart failure resulting in AKI, examples of which are acute coronary event causing AKI or heart failure causing AKI. Chronic cardiorenal syndrome is because of chronic heart failure causing chronic kidney disease. So if you remember, the difference of acute and chronic kidney disease is a cutoff of 3 months. Then we have acute renocardiac syndrome. We have the AKI coming in first, causing heart failure. So this can be because of overload from AKI causing heart failure, inflammation, or metabolic disturbances in uremia, causing our heart failure. Type 4 chronic renocardiac syndrome is CKD resulting from chronic heart failure. So this can be left ventricular hypertrophy and heart failure from CKD-associated cardiomyopathy. And then if type 5 cardiorenal syndrome is a systemic process, commonly I see this in cirrhosis, sepsis, or amyloidosis, wherein the heart and the kidney are both affected. Now, its pathophysiology is multifactorial. It can go around causing kidney problems or kidney problems causing heart problems. And usually the most popular thought is the one of hemodynamic interactions. You can have ischemia, cardiomyopathy, or arrhythmia causing a decrease in cardiac output, decreasing perfusion in our kidneys, causing an increase also in venous pressure, resulting to kidney injury. So here, clinically, we can see patients having reduced blood pressure, reduced renal perfusion, cardiac index may not be a primary driver of the renal function. So we can have HFrEF and HFpEF patients still having AKI. We can have increased venous pressure and right ventricular failure, which can cause the kidney disease. However, there are also neurohumoral adaptations. In times where there is decreased hemodynamic stability, we can activate the renin, angiotensin, aldosterone system. The sympathetic nervous system can also be affected, as well as high secretion of the natriuretic peptides, because our body detects a lack of fluid and a perceived lack of fluid and tries its best to conserve. So this further increases inflammation and oxidative stress, wherein we can have increased humoral signaling, increased cytokines, and decreased water and sodium excretion. So all of these interplay of symptoms may cause renal hypoperfusion, tubular cell injury, and other conditions which can worsen both our cardiac and kidney function. We can see this present in our patient from clinical signs and symptoms. So we can have patients who are dyspneic or thopnic, maybe having decrease in urine output, fluid overload, and edema. But largely, diagnosis is dependent on these diagnostics, which can focus on both the heart and the kidneys, both imaging and biomarkers and serology. The most simple one that we use are the blood and the urine chemistry studies, wherein we can measure the BUN and the creatinine. So its increase and the change in the EGFR can help us see the presence of acute kidney injury. The BUN creatinine ratio, though, is important in order for us to determine whether it's pre-renal or intrinsic renal. And if it's greater than 20, we can more or less surmise that maybe the heart is affected. Other centers do the urine sodium determination, and if it's less than 25 or if there is conservation of sodium, it can be due to the activation of the renin, angiotensin, aldosterone system, which increases our suspicion that maybe this is AKI from a cardiorenal or other cause. Other diagnostics are the biomarkers. So commonly in our center, we use our cardiac troponins, which is a marker of myocardial injury, indicating presence of acute coronary event or heart failure, and it can help us prognosticate for chronic kidney disease. We also use the natriuretic peptide, which is an indicator of myocardial stress, and it can help us diagnose cardiac events and prognosticate on heart failure and cardiorenal syndromes. So the others are the ones that we see here, not present in our center, but there are studies on the NGAL, cystatin C, FABP, which can be used to determine um, kidney injury. However, it's not available here. And then for the heart, we can have various imaging modalities. So, of course, we can use the 2D echo in order to see the heart function and measure the hemodynamics. So we can see the CVPs, pulmonary artery pressures, and then pulmonary capillary wedge pressures, cardiac output for the cardiac front. Now, for the kidney front, cardiomyopathy from uremia can show us alterations in cardiac function, but in the absence of strain pattern. In CKD patients, those with strain have higher mortality for chronic kidney disease patients. So in the renal front, the renal ultrasound and venous flow pattern is very helpful for us. So it can also help us determine the RA pressures. So in this study, they compared patients, those with lower RA pressures of less than 10 millimeters mercury have a favorable prognosis. But if there is discontinuous intrarenal venous flow, there can be increased RA pressures or monophasic patterns. There were the poorest outcomes in terms of our patients. And we can see here that because of the lesser flow, our diuresis may be less effective for these patients. Now, other than that, the ultrasound can help us determine the chronicity of the kidney disease because, as we remember, smaller kidneys, poorer echogenicity, and poorer corticomedullary differentiation in thickness may help us determine that this is already a chronic kidney disease or a condition which has been lasting longer than 3 months. Other options are the cardiac MRI, wherein we can have assessment of the ventricular dimensions, fibrosis, and we can see here that uremic cardiomyopathy is really muscular in nature and not usually related to coronary artery disease alone. It can also affect the muscles and cause fibrosis, and this will increase our suspicion that the patient is in type 4 CRS. Other emerging strategies are the bioimpedance vector analysis, which is a measure of fluid. So what it does is that there is a machine measuring an electric current. So it's connected to the wrist and to the ankle of the patient, wherein the electric current passes through the patient. And then if there is lesser resistance, we know that there is more increased fluid or wetness that is present in the patient. This used in conjunction with other parameters like our X-rays, ultrasounds, PE, and echo can help us determine the presence of dyspnea if it's due to heart failure, maybe acute kidney injury, fluid overload, and can guide us in increasing our dose of diuretics if our patient is still fluid overloaded. So other cardiac volume status determination strategies are the measurement of the intra-abdominal pressures. So if this is increased, there can be increased stress on the kidney because of a relative abdominal compartment syndrome. Then we can have our relative blood volume monitoring devices, our implantable hemodynamic monitoring devices. So the Champion study shows that the implantable hemodynamic monitoring devices demonstrates a lower hospitalization rate. And then for invasive hemodynamic monitoring in cardiorenal is not routinely recommended because the outcomes were not significantly different. However, of course, we would see if the patient really needs this, it can be done, but we have to assess if our patient is a good candidate, especially if the patient is in chronic kidney disease. So, if we're able to ascertain the presence of cardiorenal syndrome, how do we manage our patient? So, management in our center is largely being done well. So, on review, the first line is usually to try to dry up the patient. But the evidence based clinical practices for diuretic use remain uncertain. We usually just give it for symptom relief. Of course, our comfort, the patient's comfort is important. So most common that we use is the furosemide, wherein the intravenous one would have an action of around 30 minutes to 2 hours. And if it's oral, the action would be at around 6 hours. Then furosemide can be given as a high dose intermittent way, and it appears to be safe and effective in our patients with heart failure. Other possibilities of loop diuretics that we have are torsemide. The half-life is longer, so the dosing is less, but it's quite uncommon in our center. How does the loop diuretic act? So what happens is that in the loop, we can have the sodium to chloride transporter, and furosemide is the one that inhibits this one. So there is less absorption of the sodium, potassium, and the chloride, causing a loss of the electrolytes, pulling the water into the urinary space, causing increased exit of urine in our patients. However, in prolonged use, it can have diminished oral bioavailability. And if the GFR of the patient is increased, the furosemide can have lesser concentration in the tubules, causing lesser effect. So there is impaired sodium delivery as we proceed down into the further parts of the tubule, and we can have what we call the diuretic breaking phenomenon. In essence, what this means is that if we give the furosemide early or first, the sodium would be pulled out efficiently. But as we go along, the effect of the sodium of the furosemide and the sodium excretion would decrease over time, causing less fluid to be lost. Also, we have the loop where the furosemide is effective. What would happen is that further down the tubule, in the distal convoluted tubule, it would adjust to try to absorb the sodium that is lost. So there is less diuretic action. So what is supposed to be done is to increase the dose and maybe the frequency of the furosemide in order for us to overcome the diuretic breaking phenomenon. So if the diuresis is not effective, we can have what we call ultrafiltration. In essence, it's like dialysis. However, we are able to just pull out the fluid. So what happens is that we have an access in our patient, and then the blood goes out, passing through hollow fibers of semi-permeable material, wherein from the area of greater fluid concentration, it goes out, and then the machine is able to pull out the fluid by negative pressure. So isotonic fluid is removed from the intravascular space. And then there's less potassium wasting, less renin and aldosterone release, and increased sodium loss. However, in comparison with the diuretic, the trials for ultrafiltration also show mixed results. So our information regarding this is generally we try the diuretic first, and then if it's not working, we do the ultrafiltration. Other therapy would include the neurohormonal modulation and vasodilator and inotropic therapy. So, a relatively new medication that we have is a tolvaptan, or a selective vasopressin 2 receptor antagonist, acting on our collecting duct, which causes the loss of just water and no electrolytes. So, it showed great weight reduction in the patients, but in terms of outcomes for hospitalization and mortality, there have been less than ideal results. And then for the other vasodilators like nasirotide and dopamine, there have been no significant differences in terms of outcomes. As such, the renal vasodilating dose has not been used in the recent years. So of course, what's important for the heart and the kidney are the A's and the ARBs for the renin, angiotensin, aldosterone system inhibition, which has been established in preventing the progression of chronic kidney disease. So in several studies, it has been shown that there is a marked reduction in heart failure associated mortality and symptom burden, but we need to watch out for the doubling in serum creatinine. And then there is less hospitalization from heart failure. And then a meta-analysis has shown that even if sometimes the creatinine increases, we really don't need to discontinue if the increase in the creatinine is less than 20%. And then there is a significant reduction in mortality for some patients. So another new drug is the neprilysin renin angiotensin inhibitor. So here we have the different studies, and then the results generally show a decrease in death and hospitalization from heart failure. Sometimes it's more hypotension, but less renal dysfunction and hypokalemia. So this is also a therapy that we can give. So other than this, usage of these drugs showed reduced BNP, blood pressure, and atrial size. And there is lowering of the blood pressure and cardiac biomarkers, as well as improvement in kidney function and albuminuria of our patients with CKD. So another classic drug, but with a newer type, we have our spironolactone, eplerenone, finerenone. Finerenone is the newest one on the block, the MRAs, which have showed that it has safety and efficacy in heart failure with advanced CKD, but for the advanced, the data are limited. So normally we can give it for those with symptomatic heart failure, those with elevated BNP levels, with heart failure admissions within a year. It's safer for patients with a relatively preserved eGFR of greater than 30 or a creatinine of less than 2.5. But if we need to consider this for our patients with heart failure in CKD 4 and 5, there is an increased chance of hyperkalemia. So we need to monitor potassium in these patients. The evidence in terms of their efficacy for CKD 4 and 5 or advanced is quite weak. So we need to be careful. Another pillar is our beta blockade, or our armamentarium is the beta blockade, which can improve our class of the heart failure as well as the ejection fraction and alleviate symptoms and hospitalization burden. So renal wise, what we just need to watch out for is that even if it prolongs survival and reduces mortality, there can be an increased fluid retention. So we need to watch this out for our patients if they are being congested. So the effects are seen regardless of kidney stage. There is improvement in terms of the hospitalizations, and it decreased the all-cause mortality. So here is a summary of the different treatments that we can have for cardiorenal syndrome. The strong evidence is seen for those with preserved kidney function in terms of resynchronization therapy, are implantable devices. And for the medications, the strong medications that we have are beta blockers, MRAs, ARNIs, and the ACE and the ARBs. So the evidence, though, for advanced chronic kidney disease are quite mixed. So we need to be careful when giving these drugs to our patients. And of course, part of the armamentarium that we have for controlling cardiorenal syndrome are the medications for glycemic control. So traditionally, we have the metformin, which is highly effective, does not cause weight gain, and may reduce cardiovascular events, and the newer medications. But I'd like to focus on our SGLT2 inhibitors. So historically, it was started for glycemic control in type 2 diabetes, but was seen in subgroup analysis and further studies for DAPA and EMPA for reduction in major cardiovascular events in patients with type 2 DM and established cardiovascular disease. Kidney-wise, the studies showed reduction in eGFR decline and hospitalization. But we need to ensure that if we start this for patients with CKD, there is no hypovolemia to avoid AKI. Because if we remember, the SGLT2 inhibitors act on the proximal tubule. It blocks the sodium glucose transporter. So the sodium and the glucose exit through the urine, pulling also with it the fluid. So we need to avoid hypovolemia for our patients, optimize volume status before initiating therapy. So DAPA is now approved for patients with heart failure as well as EMPA. So in fact, in terms of the clinical practice guidelines for the AHA, the European, as well as the kidney guidelines, the SGLT2 inhibitors are a 1A recommendation. Now, other off-label uses are for management of obesity and NAFLD for our patients. So, for implantable cardiac devices, this is usually a cardiac competency, but I like to bring our attention to our patients who have advanced chronic kidney disease that we need to consider if they are optimal candidates for this. So, things we should ask is that if there is a clear survival benefit, if the multidisciplinary assessment was done, maybe if we maximize our pharmacotherapy before we consider the device. We need to make sure that the device does not impede vascular access for dialysis, or as an alternative, if we can consider subcutaneous or epicardial devices. And also, how we, as nephrologists, we need to adjust the dialysis prescription in order to reduce the rapid flux of electrolytes and fluid shifts. We need to be careful about infection control, and we need to make sure that we know the patient's life goals so that we know if these are appropriate for our patient. Of course, sometimes our medications cannot help out those who are severely in kidney and heart failure. So, palliation is something that we must consider. So, patients can have high mortality, healthcare resource use, and poor quality of life. And things we need to contend with are volume overload, which can present with dyspnea fatigue. And our patients can also become depressed with a depression comparable to cancer patients. So also things we need to consider for chronic kidney patients are full precautions because of bone mineral diseases. And then if our patients are in chronic pain, we can maybe refer to the pain service and consider opioids, as NSAIDs are not good for the heart and the kidney. So we can consider hydromorphone, oxycodone, fentanyl, and methadone. And of course, maybe have advanced care planning for our patients and have multidisciplinary care for our patients. So I'd like to summarize with the major adverse events that can be present in our patients, both renal and cardiac. So we can have progression of acute kidney injury, strokes, MI, hospitalization, dialysis, progression of CKD, heart failure, and death. Now, these are important because I think we need to tell the patients about these possible concerns in order for advanced directives to be in place so that we can ready to manage them accordingly as per their wishes. Now, I have to delve a bit on perioperative management of acute kidney injury because many of our patients come in for procedures. So what's important to remember is that if your patient is coming in for maybe cabbage or an angio, we need to check for cardiac surgery associated acute kidney injury risk factors. Usually the elderly and the females with preoperative cardiac dysfunction, peripheral arterial disease are at high risk. We can also check for the type of the surgery and it's being emergent. It's if it's a reintervention, and of course, those with diabetes and CKD are at higher risk for AKI. So if we have these subset of patients, we can refer to the nephrologist early on in order to prime our patients for the possibilities of renal replacement therapy. Several risk calculators are available. You can check this out in our QX Calculate, wherein usually we can have the descriptions of our patients included in the calculators. However, there are different models that are being created in the other centers, which are center specific. So we need to watch out for these. Now, the KDGO bundle for cardiac surgery associated acute injury would want us to be reminded to discontinue all nephrotoxic agents, prevent radiocontrast procedures if we can, control sugars, monitor the urine output and serum creatinine, and maintain adequate perfusion and volume in our patient, and consider a functional hemodynamic monitoring. When they did a study of patients who underwent the KDIGO bundle, they saw that the compliance for this one was about 5.3%. So I would like to encourage ourselves, the nephros and the cardios, also to watch out for these events in order for us to prevent AKI in the surgical setting. Now, sometimes times we're not able to prevent renal replacement therapy. So the different types of renal replacement therapy that we have in our center can have the intermittent hemodialysis, prolonged CRRT, and of course, here we don't do the peritoneal dialysis. Indications are usually the following: uremia, hyperkey, hypervolemia, metabolic and fluid demand, to capacity imbalance, and acidosis. So we can have here that usually the highest reason for us initiating dialysis would be the metabolic and fluid demand to capacity imbalance. Next of which would be hypervolemia. So we can watch out for these in our patients. Now, usually dialysis or renal replacement therapy would be of three types. We can have the intermittent dialysis, which is less in frequency and is the fastest one. Usually it's done for 3 to 4 hours. And then daytime, we can use the fistulas or the central venous catheters of our patients. So it can have a fastest blood flow rate, and this would be difficult for our patients who have poor cardiac function. So we also have CRRT now in our center. So continuous renal replacement therapy is the one dialysis that is closest to the kidney function in terms of its gentleness and slowness in the heart. So it is continuous. When we start it, we try to do it as long as possible as the patient needs it or if there is no clotting in the bloodline. However, it is usually done through the central venous catheters and in the ICU. Now, if the CRRT would be difficult for our patient, we can consider the slow low efficiency dialysis, which is a combination in terms of benefits for both the intermittent hemo and the CRRT. So usually it occurs at 6 to 12 hours in terms of duration, but may be done more frequently because it has a low efficiency through a central venous catheter. And then the blood flow rate, if we note, is in the middle of the intermittent and the CRRT. So these are the options for our patient. So with that, I hope that I was able to give a practical way in order for us to manage our cardiorenal patients in terms of the epidemiology, the different syndromes, the diagnosis, and the management. So I'll be open to questions that you may have. You may also message me if there are any concerns that you have. Thank you very much and have a pleasant day.